You've done everything right. You cut the salt. You walk every morning. You take the lisinopril, the amlodipine, maybe a diuretic on top. And your numbers are still sitting at 150/90, 160/95. Let me tell you something I say to my patients every single week. That is not your fault. For about 1 in 8 adults over 60 with high blood pressure, the standard pills were never going to fully work. They were never designed to fix what is actually broken in your body. There is one drug, brand new in 2026, that targets the exact reason your current pills are failing. I will tell you its name before this video is over. I'm Dr. Richard James, a senior health physician with over 3 decades of clinical experience. Over those decades, I have watched too many patients sit in my exam room, blood pressure cuff on their arm, eyes full of frustration, asking the same question. Doctor, what am I doing wrong? For about 1 in 8 of them, the honest answer is nothing. You are not doing anything wrong. Your pills are doing exactly what they were designed to do. They are just not designed to fix the problem you actually have. The clinical term for this is resistant hypertension. It is blood pressure that stays elevated despite 3 or more medications, including a diuretic. According to the American Heart Association, roughly 1 in 8 adults with high blood pressure meet this definition. In adults over 60 with diabetes or chronic kidney disease, the number is closer to 1 in 5. This is not rare. This is one of the most under-recognized problems in cardiology right now. Here is the part that should genuinely concern you. Every year your blood pressure sits above 140/90. The inner lining of your arteries is being scarred, microscopically, day after day. Your kidneys are filtering harder. Your heart is pumping against more resistance. And by the time the damage shows up on a test, a real percentage of it cannot be undone. Before I tell you the name of the new drug, you need to understand the one hormone system that most blood pressure panels are not measuring. Because once you understand that, you will see exactly why every pill you have taken so far has been working on the wrong problem. Pull out your pill bottles right now if you can. Read the names on them. Most of you will see 1 or 2 of 4 things: a drug ending in pril, a drug ending in sartan, a drug ending in ipine, or a water pill. That is essentially every standard blood pressure regimen in modern medicine. The pril drugs are called ACE inhibitors: lisinopril, ramipril, enalapril. They block an enzyme in your bloodstream that would otherwise tighten your arteries. The sartan drugs, things like losartan and valsartan, are called ARBs. They block the same tightening signal, but a step further along. The ipine drugs, like amlodipine, are calcium channel blockers. They relax the smooth muscle inside your blood vessel walls. The water pills, hydrochlorothiazide and chlorthalidone, push extra salt and fluid out through your kidneys, lowering the volume of blood your heart has to push. For the majority of adults with high blood pressure, that combination is more than enough. 2 pills, sometimes 3, and the numbers fall into a healthy range. The system works. But there is a specific group of patients in whom none of these 4 classes, even taken together, will ever fully bring the numbers down. The reason is something almost no doctor takes the time to explain at the prescription pad. Your body has more than one system controlling blood pressure. ACE inhibitors and ARBs target one of them. Calcium channel blockers target another. Diuretics flush out fluid. Behind all of them sits a 5th system, a hormone system. In roughly 1 in 8 older adults with high blood pressure, that 5th system is the one that is actually driving the problem. None of those 4 pills touch it. Think about what that means. You can stack 3 medications. You can take them perfectly, every day, at exactly the right time. You can cut the salt, walk the dog, lose 10 pounds. And if that 5th system is the one running the show, every one of those pills is, in a sense, hitting the wrong door. The room you need to get into is locked behind a door none of them carry a key for. This is one of the most quietly frustrating problems in modern cardiology. Patients do everything right. Clinicians prescribe everything correctly, and the numbers refuse to come down because nobody has tested for the system that is actually elevated. In my own practice, I have watched this play out for years. A woman in her 60s on 3 medications for a decade and a half. No change. A retired truck driver on 4 medications, still 160/95 every visit. They are not outliers. They are a recognized clinical subset, and the medical literature has had a name for what is happening to them for 60 years. We just did not have a good tool to test for it routinely, and until 2026, we did not have a drug clean enough to use confidently in the older population. So what is that fifth system? Stay with me, because this next part is going to make sense of every failed blood pressure reading you have had in the last decade. The hormone system most blood pressure panels are not measuring is called aldosterone. Your kidneys do not decide on their own how much salt to hold on to. They take orders. The hormone giving the orders is aldosterone, produced by two small glands sitting on top of your kidneys called the adrenal glands. In a healthy body, aldosterone rises and falls based on what you need. When you are dehydrated, it tells your kidneys to hold on to sodium and water. Pressure goes up. When you have plenty of fluid on board, aldosterone drops, and your kidneys let salt go. In roughly 1 in 8 to 1 in 10 older adults with high blood pressure, aldosterone is stuck on high. Your adrenal glands are simply producing too much of it, all day, every day, regardless of what your body actually needs. The medical term for this is primary aldosteronism. It has a simple, inexpensive screening test, a blood test called the aldosterone-to-renin ratio. This is the part that frustrates me the most as a doctor. We have known about primary aldosteronism for 60 years. The test costs almost nothing and takes a single draw. Yet study after study, published in journals like Hypertension and the Journal of the American College of Cardiology, shows that the aldosterone-to-renin ratio is being ordered in fewer than 2% of resistant hypertension cases. Read that again, 2%. The other 98% are walking around with a treatable cause of high blood pressure that nobody is even looking for. Let me tell you about a patient. We will call her Gloria. She was 71 years old, a retired school teacher from a small town in Ohio. Her husband had died 3 years earlier. She had moved in with her adult daughter. She had 2 grandchildren she walked to school every morning. She came into my office with a chart that read like a textbook. Lisinopril, amlodipine, hydrochlorothiazide, 3 medications taken faithfully for 15 years. Her readings were 156/96. They had not moved. I ordered an aldosterone-to-renin ratio. The number came back well above the threshold for primary aldosteronism. We confirmed it with a follow-up test, referred her to an endocrinologist, and within 6 months on a targeted regimen, her pressure was at goal for the first time since she was 56. She told me at her next visit that she had stopped waking up with headaches. She had stopped feeling like her chest was tight every time she climbed the stairs. This is a representative profile, the kind of patient any clinician working with older adults sees in resistant hypertension. The clinical pattern is real, and it is exactly what happens when the right test is finally ordered. Here is the part that has been missing from this entire field until 2026. Even when we do find elevated aldosterone, the medication we have had for decades comes with side effects that limit who can take it. The drug is called spironolactone. It works on aldosterone, but it brings real problems, especially in older men. Breast tenderness, sometimes high potassium, sometimes erectile changes. A lot of patients either stop taking it or are never offered it in the first place. So we knew the cause. We just did not have a clean tool to fix it. That brings us to the breakthrough. The drug is called Baxdrostat. It is what is known as an aldosterone synthase inhibitor. That single word, synthase, is what makes it different from anything we have had before. Spironolactone tries to block aldosterone after your adrenal glands have already made it. The hormone is already in your bloodstream, and the drug spends its time mopping up after the fact. Baxdrostat goes upstream. It blocks the specific enzyme inside the adrenal glands that produces aldosterone in the first place. The result is that the hormone simply never gets made in the excess amounts that are pushing your blood pressure up. The evidence for it is real, recent, and published in one of the most respected journals in the world. The trial is called BaxHTN. It was a Phase 3 study published in the New England Journal of Medicine in 2025. The researchers took approximately 800 patients with treatment-resistant hypertension, people already on at least 3 blood pressure medications, and randomized them to receive Baxdrostat at 1 milligram, Baxdrostat at 2 milligrams, or placebo, all added on top of their existing regimen. After 12 weeks, the patients on the 2 milligram dose saw their systolic blood pressure, the top number, dropped by approximately 9 to 11 points more than the placebo group. That is not a small effect. That is a meaningful, sustained reduction in patients whose pills had been failing them for years. And a sustained 10-point drop in systolic pressure has been shown across decades of cardiovascular research to reduce stroke risk by roughly a third. Heart failure hospitalizations fall as well. Kidney decline slows. The downstream impact of a number like 10 millimeters of mercury is enormous when you carry it across the rest of a person's life. The FDA is currently reviewing Baxdrostat in 2026, with the agency's action date expected in the second half of the year. If it is approved, it will not replace your lisinopril or your amlodipine. It will be added on top of them for the specific patients in whom the standard 4 classes have not been enough. Think of it as the missing 5th piece, not a replacement for the first 4. Now, I have to be honest about what this drug is not. It is not approved yet. It is in late-stage FDA review. Until the agency acts, it is not something you can fill at your pharmacy, no matter how perfectly you fit the profile. It is not for everyone with high blood pressure. It is specifically for resistant hypertension, the 1 in 8 whose numbers will not come down on standard therapy. It is not a replacement for your current pills. The trial added Baxdrostat on top of an existing regimen. That is how it is expected to be used in real-world practice. And like every drug, it has potential side effects. The most important one to know about, because it relates directly to its mechanism, is the risk of elevated potassium. Aldosterone normally tells your kidneys to dump potassium. Blocking aldosterone production means potassium can rise. That is something your doctor will monitor with a simple blood test. For the 1 in 8 older adults with resistant hypertension, this is the most significant blood pressure development I have seen in my career. We finally have a tool that hits the right system, with a side effect profile clean enough to use confidently in older patients. So, how do you actually get this conversation started with your doctor? What test should you ask for first? What should you say? And when does it make sense to bring up Baxdrostat by name? In a moment, I will give you the exact protocol I would walk a family member through. I know what some of you are thinking right now. If aldosterone testing were really this important, surely my doctor would have mentioned it by now. I understand why it feels that way. You trust your doctor. You see them every 3 months. You believe that if there were a simple test you were missing, they would have ordered it. Here is the honest truth. The aldosterone-to-renin ratio is not part of the standard primary care hypertension workup. It is typically ordered by nephrologists or endocrinologists, not family physicians, and usually only when a patient or specialist specifically requests it. The numbers I mentioned earlier, fewer than 2% of resistant hypertension cases getting tested, are not because of negligence. They are because the test does not appear in the standard clinical pathway. It is a gap in the system, not a failure of any one doctor. The same is true for Baxdrostat. Until the FDA acts, it is not on any formulary. Most cardiologists are not bringing it up in routine visits yet because there is nothing they can prescribe today. They will start discussing it the moment approval lands. Your job, between now and then, is to make sure your doctor is the kind of doctor who will bring it up when that day comes. I had a patient, 68 years old, on 3 medications for over a decade. She came in one afternoon, half apologetic, and said, "Doctor, I read something online about a hormone test for blood pressure. Could we run it?" We ran it. It was elevated. Within 6 months on a targeted regimen, her numbers were at goal for the first time in 15 years. The difference between her and most patients with resistant hypertension was not her physiology. It was one direct question. That is the gap you can close at your next appointment. So here is exactly what I want you to do. Write this down if you can. Step 1. At your next appointment, say one sentence to your doctor. Use this exact phrasing if you want. Given that my blood pressure has not come down on the medications we have tried, would it make sense to run an aldosterone-to-renin ratio test? That one sentence reroutes your entire workup. Even if your doctor is not familiar with the name, they will know exactly what to order once you say it. Step 2. If your doctor agrees to run the test, make sure the blood draw is done correctly. Aldosterone testing is sensitive to time of day, posture, and medications. The standard approach is a morning draw, while you have been sitting upright for at least 5 to 15 minutes before the blood is taken. Ask your doctor a follow-up question. Are there any of my current medications I should pause for a few days before the draw? They will guide you on the specifics safely. Step 3. If the ratio comes back elevated, do not let it sit in your chart. Ask for a referral to a nephrologist or an endocrinologist. Those are the specialists who will confirm primary aldosteronism, walk you through treatment options, and pay close attention to Baxdrostat as the FDA action approaches. Step 4. Mark your calendar for late 2026. If Baxdrostat is approved, it will be added on top of your existing medications, not in place of them. At your next specialist visit after approval lands, ask one more sentence. Now that Baxdrostat is approved, would I be a candidate? You went into this video frustrated because your pills were not working. You are leaving with a hormone name, a drug name, and a specialist path. That is the difference between hoping things improve and actively changing the conversation. Most patients with resistant hypertension will go their entire lives without ever hearing the words aldosterone synthase inhibitor. You just did. That puts you significantly ahead in the conversation with your doctor, and that matters more than you may realize. If this gave you a path forward you did not have before, subscribe, because next I am covering something just as important that almost nobody talks about. What your blood pressure is doing while you sleep, and the one sleeping position that can quietly drive your nighttime numbers dangerously high after 60. Take care of your heart tonight. I'm Dr. Richard James, and I'm rooting for you.